Hi, good afternoon. So my name is Dr. Anish Bhuva. I'm a cardiology registrar in London in Bart's Heart Centre, and I'm a clinical lecturer at University College London. I work closely with Cardiomyopathy UK on MRI provision for people with pacemakers and defibrillators, which is what brought the concept of this session about today. So I'm really looking forward to taking your questions and answering them as best as I can. I want to first start with an overview of cardiac devices. We've got a parallel track at the moment, which concentrates a little bit more on the various therapeutic indications and reasons for implanting a cardiac device. But I think it's important to know what they are, at least for this session, for an overview, and then so that fits into the implications. And I want to focus more on the implications of living with a cardiac device. And we'll go through that in brief. And as our work largely is on magnetic resonance imaging in the context of having a pacemaker or defibrillator, I want to focus on the practical aspects of that, at least in the UK, although I know the audience is worldwide. The guidelines, protocols, but also the system, most importantly, is changing a lot on that. And so I'll talk about that for the UK, but it has wider implications as well for the rest of the world. So broadly, cardiac devices in this context are implanted for three main reasons. If you have a slow heart rhythm, if you have heart failure, or if you have sudden death due to fast, life-threatening heart rhythms. And the devices put in for these are defibrillators, ICDs, cardiac resynchronization therapy devices for heart failure, or pacemakers to treat the slow heart rhythms. The overview of what these devices are really quite straightforward, although of course the technology has been around for 60, 70 years. The software has increased in complexity. The basic function of a pacemaker is still fairly static. And the idea is to sense when the heart is missing a beat or slowing down. And in the crude diagram I've shown you on the left, hopefully it shows the simple components of a pacemaker, in that the blue wires connected to the heart can read when the heart stops beating through the lack of electrical signal. It then switches on a timer and then an on switch to deliver an impulse and a trigger to the heart to beat again. But of course, all of this needs a battery, and the technology for that still is maturing. And so the key components of our pacemakers are the generator, which contains the on and off switch for triggering when the heart should beat, the battery, which is contained in the box of the generator. Then you've got the leads, and you can see on the picture on the other side of the screen that there's two leads, one to the top and one to the bottom of the heart. And the reason for that is the filling chambers at the top of the heart need to synchronize with the lower pumping chambers of the heart. At the tip of these leads are electrodes. So they read what's happening in the heart, and based on that can decide whether to deliver an impulse or not. So it's fairly straightforward in what it needs to do, and it does it really well. But these devices can be more complex as well. And it's taken a while to build in that complexity. If you look in the 1950s, Dr. Zoll, when he developed these first devices, were really quite large. They lasted for hours and eventually days. And the devices that were around in the 1950s were large tabletop devices. So really limited the use and quality of life for patients. And that led to the establishment of the Zoll Manufacturing Company, and now a whole industry built around this. And as you can see now, our pacemakers are fairly small. I've got a pound coin there, but really these devices are the size of 2 to 3 finger breadths. They're not on a table anymore. They're now implanted typically under the left collarbone. And the two leads feed into the heart through the vessels. So you still notice them, but they're a lot more convenient and essentially compatible with day-to-day living as prior to implant. We've then understood a little bit more about how hearts pump and in improving the coordination of pump function. And often this is lacking in people who have heart failure, which is a terrible term, but really means the heart struggles to pump as much as it should be to the rest of the body. So it's not failing, just not meeting the body's requirements. And when it does that, it can often be very desynchronous. So it's not coordinating efficiently. And so a new type of pacemaker that has been around a lot more recently is a pacemaker with 3 leads to the heart. The 2 leads off the original pacemakers I was showing you, but a second lead to the second pumping chamber, the main pumping chamber of the heart. And having a lead on one side and then far on the other side means that the pacemaker can coordinate the contraction of the heart. In doing so, it should improve the contraction and hopefully symptoms as well. And we've mentioned pacemakers, but CRT devices can also come alongside defibrillators, which I'll touch on. I wanted to also mention the newer models of these devices, and these are leadless pacemakers. And again, are fairly new. You can see they're very small devices. And I think the important thing to recognize here is that these devices you can't see or feel or touch. They're implanted within the heart with nothing sitting on the chest cavity like we were talking about before. And the X-ray on the right just shows how small these devices are. Defibrillators, on the other hand, will have a pacemaker function to them, but they do something else. As you can see from the external defibrillator, hopefully that provides an example of how effective these devices are at reversing potentially death from a life-threatening fast heart rhythm. And they do that by delivering an electrical voltage to the heart, a shock to the heart, so its heartbeat, normal heartbeat, resets. So these devices are larger than pacemakers, but now are typically implanted in the same fashion, and the procedure is fairly similar, and they can have 1 or 2 leads. We also now have a growing array of tools, and this is because we recognize that whilst it took a while for the battery and generator to evolve and mature, that technology is fairly stable now. Of course, it's always improving, but the larger weakness in the system is the leads. And when leads are implanted within the vessels, there's a chance that over time they can get damaged or they can get infected. So these devices essentially are devices that sit over the ribcage, so don't touch the heart at all. And they deliver shock therapies very effectively as well. On the very other side of the spectrum, you've got these smaller devices. These are implantable cardiac monitors. I show you a common one here, but there are a number now. And these are fit about the size of a few matchsticks under the skin to monitor the heart rhythm. They don't deliver any therapy, but they can be useful for monitoring if there's a suspicion of abnormal heart rhythms. And often these will be now connected to your phone with a transmitter, and clinicians can look at them remotely as well. And so they work fairly seamlessly and are fairly easy to install within normal life. But what this all means is that both pacemakers, defibrillators, and monitors, they're all very effective at doing what they need to do. And I think the case of the first person to have a pacemaker implanted, so under the skin, highlights this very well. So Arne had a pacemaker with multiple generator changes, and the reason for multiple is because the batteries weren't as durable as now, so they required multiple generator changes. He had different leads because, of course, the leads may require changing as well. And he went on to live a long and healthy life, dying at the age of 86 from other causes. And this was in 2001. And what this illustrates now is, again, technology's improved far beyond Arne's lifetime, is that we now need to think about this is a lifelong consideration, having an implanted cardiac device. And that has a number of implications that requires regular follow-up, both to check on the device integrity, also on whether the device has picked up any abnormal heart rhythms or other medical concerns. And then, of course, the device itself, the software, may need programming. Having a cardiac device has implications for other medical care, but also real-world living, travel, insurance, driving restrictions, and equipment interaction, just amongst a few. And for this reason, in the 1970s, the European Union developed an identification card. With any medical device, it's important to know the details of it for a number of reasons and to be carried on one's person. And so these are paper cards with the necessary details. These haven't changed much over the last 40 years and are still used today. But what has changed is the complexity of our care and the system, both around devices, but in how they interact with our lifestyles. As Arne's example highlighted, he lived with a device for many years and had essentially a life besides generator changes, which was as he wished. But you do need to take considerations into account. And so the record needs to be within the medical notes, but also held by the individual themselves and shared with wherever necessary. And here I want to focus, as I've said, on magnetic resonance imaging. And so the reason I want to do this is because of its use in day-to-day medical care. The way a magnetic resonance imaging machine is designed, it contains a strong magnet, and the magnet produces really detailed pictures of the body and the tissues that make up the body. As you can see from the pictures on the right, you've got a section or an image of a brain and a spine, and you really get the detail. This makes it quite useful in day-to-day medical care and modern healthcare. And it's a very safe technology. Over 300 million scans have been provided worldwide, and the vast majority of those are performed safely and without any concerns. And the reason for that is because there is a strong focus on MRI safety. Because there is a magnet, it needs shielding and needs protection and control. So other ferromagnetic objects, so metallic objects attracted by magnets, aren't brought in the vicinity of the scanner. And all the equipment you can see in this room is designed so it can be safe within the environment of an MRI machine. So how does this fit into the session today? And I've put this as a number of questions that we get commonly asked. The first being, will I need an MRI scan if I have a cardiac device? And the answer is really like the rest of people who don't have a cardiac device. Nowadays, in the UK and USA at least, 3/4 of us will need a magnetic resonance imaging scan because they can give detailed images of the body. It doesn't mean it's the only technique to do these, to get the answer, but this is often for common indications. And it's increasingly used, particularly to treat brain tumors and other cancers, or to avoid biopsies, such as for the prostate or for spinal tumors. If one has a pacemaker, however, because it's a large metallic object sitting within the body, there have been historically understandable safety concerns around this. So the sign in the middle of my slide here shows what's on every MRI door across the world, where it says that no pacemakers, implants, or neurostimulators, which are other implanted cardiac devices, are allowed within the magnetic field of the magnet. So what that meant is that by creating MRI and pacemakers, we as a healthcare profession were also building a healthcare inequality of our own doing, where people with pacemakers, 500,000 in England, about 5 million in Europe, they didn't have access to the same level of healthcare as others for care reliant on MRI. And if you look at how this is changing over time, MRI, at least 3 years ago, was the fastest growing imaging modality within the national healthcare system in the UK because of the reasons I've mentioned. The number of implants for cardiac devices, defibrillators or pacemakers is also growing at about 15% a year. On the right, I've got a chart of the implant rates for Europe, and the UK fits fairly low. And I think that is low considering the population of the UK as well. And so rates, at least in this country, are still likely to rise for a while. And what that means is that the need for MRI in our population of people who have pacemakers or defibrillators is only increasing. And so we've talked that an MRI may be necessary, that it can be useful in certain indications. We've said that if you have a pacemaker or defibrillator, it can interact with the MRI machine. And so we have to be very cautious about entering an MRI environment. The modern practice, however, has changed, and I want to go into that in a bit of detail. The first question we now get asked is, can I have an MRI scan with a cardiac device? And actually, the short answer is yes, if it's needed. But there are a few important things to think about. Your clinician may not necessarily know about the device which is implanted, so you have to tell them and the MRI service when organizing the appointment, because as we've said, there can be significant interactions between the MRI and the device, which we do need to consider. And that does need special preparations and logistics. So it needs to coordinate the team from a number of different groups of specialties. And that's unusual in healthcare. Most healthcare is provided by a single person or a single team or a single department. In this case, it needs not only cardiac specialists, heart specialists, and imaging specialists, but also it needs the involvement of MRI physicists. It needs the referrer input as well, and often the patient to coordinate everything and make sure it can be delivered safely. So this is the modern process of getting an MRI scan if you have a pacemaker or defibrillator. I'll just walk you through this. So before the scan, looking at number one, a decision should be made first with your doctor, and that's the referring person for the MRI scan. They, of course, need to be aware that a device is present, and you need the technical details of the device, which need to be passed on to the MRI scan. And the reason for that is to check exactly what that device is. And I'll go into that in more detail because that will determine how the scan is performed safely. Some devices may not have been tested in an MRI environment, and these need a separate pathway where we need to consider other options as well and the potential small risks of these. Once the MRI is booked, on the day of the scan, it's important to bring the details of the device because it will be checked again. As you can see in figure 8 now, the device is programmed and checked as a normal device check and nothing more, but it's programmed in ways so it's set for the MRI environment. During the scan, it's very similar to a normal MRI scan where you just have to lie on a bed for the duration of the scan, but there is extra monitoring of your heart rhythm. Again, it's normal practice to be able to contact the person performing the scan, the radiographer. And once the scan's finished, the device is reset back to its usual settings. And we've said it's important to check the details of the device. And that's because there are different types. The more modern pacemakers are now tested to undergo MRI scanning. And this was an industry initiative from about 2008. And it's because the industry recognized that patients weren't getting access to the same healthcare as everyone else. And so they designed modern MRI conditional pacemakers to undergo MRI. And so they designed the leads from the bottom up, really, from designing the ferromagnetic components to extra shielding for the computer systems, changing the switches within the device as well so they don't respond to a magnet. But they still need strict settings. It still needs the logistics to do this. And then you have other devices which may not have been fully tested in an MR environment. So we now know that these can be scanned, but the referral process is different. And there's different terms for this. I've given you three there, but the terms will vary. And so these modern devices now come in all sorts of varieties. So all the devices I've talked you through earlier are available in MR conditional models from different manufacturers. And that includes the leadless pacemakers and the subcutaneous devices. And the technology that's gone into them is really remarkable. And we know that they can undergo MRI very safely. There's a lot of data to date about that now. But one has to take those steps to make sure that they can be done by tweaking the MRI scanner and tweaking the device itself. At least in the UK, this is now industry standard. So the vast majority of implants in the UK are MR conditional. There will be a few that aren't for various reasons, but this should really be the standard. There are different pressures across the world for this, and that may be related to cost, financial pressures, or other reasons. But at least in the UK, we're doing pretty well here. So if you need an MRI scan, we've said that it's important to tell the referring clinician, and the referring clinician has to pass on a lot of details to the MRI team. But it's important to know what those technical details are. And that's difficult for a clinician who's not an expert in cardiac devices, and maybe information hard to find. So what we've done in the UK is change the guidelines back in 2018. And what it says here is patients should not be denied access to MRI scanning because lack of the support for MRI provision. So whilst we're excellent at implanting MR conditional devices, it does take a lot of logistics to support these services too, and we now recognise that we need to do this. And one of the important changes was to introduce the device identification cards that contain this information as a yes or no. So it is simple for a clinician who's referring to be aware, and for the patient and individual themselves. But if you don't have this info, you can ask your cardiology team. At least in the USA, manufacturers are very proactive at handing this information out to individuals who have a device with the right authorization. I've mentioned also that there are older devices that haven't undergone testing. Of course, patients with those devices may still need MRI scans too. And since 2017, we've understood how to perform these MRI scans at really fairly low risk. There still needs to be a risk-benefit decision, but that risk is small following strict protocols. And this led the authors of a large registry paper in the New England Journal to say that it confirms pretty much anybody who has a pacemaker or defibrillator can, with few restrictions, safely get an MRI scan if they need it. And if you go back, that's a huge sea change to 20 years ago to the signs on our MRI units now. And so if one falls into this group where you've been told that you cannot have an MRI scan due to the risk, but the subject has now been raised of potentially needing one, it can be a very stressful situation, particularly if there's an important diagnosis that's outstanding and potentially delayed. And so the latest evidence tells us that scans can be performed, but there's always a small risk, but if the benefit outweighs that. So that discussion needs to take place with the MRI experts, the referrer, and of course, individuals themselves. They need to be performed for an important reason. There's got to be a good reason to perform that MRI scan. There should be no other way to get that information. But of course, these are not normal MRI scans. They need a lot more programming, different monitoring, and the right support arrangements. And so they need to take place in specialist centres. And it may be that hospitals cannot perform an MRI scans. Alongside cardiomyopathy, okay, we've noticed that this is a common question. And unfortunately, because of the logistical demands, it has been hard to develop these services at the sufficient rate for individuals who need important diagnoses which are time sensitive. And so things are changing. We performed a survey across the country of MRI departments back in 2014 and repeated it in 2019. We found that actually service was improving. So this is on the left here, but still half of patients didn't offer MRI services. And there were a number of regions that had limited access to MRI, which makes it hard often to find a hospital. And there's data from Italy, the USA, Australia, and other countries which show similar patterns, unfortunately. And the reasons for this is because it is logistically complex and technically complex. It crosses silos of medical care that we're not used to doing. And so once a clinical decision is made, it has to go through a web of imaging experts, heart experts. It has to go through the right specialists within the hospital before a patient can be brought to the MRI scanner. That can be complex and time consuming. And so at least for the UK, but also abroad, we've developed a referrals network. So referrers can find centres easier. This is out of date. There's about 60 centres in the UK and more worldwide now. But we often get emailed by patients looking for MRI services nearby to them. And we do our very best to put them in touch. But it shouldn't be patients who are the best advocates here. It should be the clinicians being able to refer, similar to MRI scans, for people who do not have cardiac devices. And so we've also developed an electronic referrals process just to simplify the consent, the communication, the risk benefits, and the complex protocols for clinicians. And this is starting to be used now in the UK, and hopefully we'll see that it saves time to get to the MRI scanner and makes it easier for everyone involved. So I'm going to pause there because I think there's a few questions that have come through in the chat. All I want to say is that there are more educational resources online. You can find details a little bit more about those questions, and Cardiomyopathy UK nurses are aware of this and hopefully can signpost now to the necessary information or resources available. Thank you very much.
Thank you so much, Dr. Bhuva. Dr. Bhuva, the question with the most likes is what are the factors in deciding on device type, in particular SICD versus traditional ICD? Is it possible to switch from ICD to SICD?
So I think the two questions there are about SICDs versus conventional ICDs, and then is it possible to switch? So for those who may not be aware, SICDs are an abbreviation that refers to a new type of defibrillator, which is called a subcutaneous implantable cardioverter defibrillator. We talked about that, and the key difference here between a conventional defibrillator is that the leads and the device all sit outside the heart. So there's nothing sitting within the heart for these devices. I mentioned already that the weakest point probably of our defibrillators is the lead. It's got to last a lifetime, and when it sits within the heart, it's moving alongside the heart with every contraction. So that will put wear and tear on it, and that will mean, unfortunately, for a minority of people, these leads can break down. And when that happens, new leads need to be implanted, or it can cause the device to malfunction. And so these are risks, which are unfortunately fortunately low, but are hard to avoid completely. There's also a risk of infection with devices that sit within the heart. And taking those devices that are infected out is a major procedure. And so with all of that known, the concept of a device sitting completely outside the heart came to bear. And that's been present really for less than 10 years now. But the trials suggest these are effective devices at delivering the essential therapy. So that is shocks when a life-threatening heart rhythm is there. So they work very well. But there are different considerations, and these need to be balanced with your clinician. The device is implanted in a different manner. Again, it's a device that sits outside the heart, not inside. It's a larger device, which needs to be considered as well. And it has different capacities to a conventional defibrillator. By that, I mean the software is different and the programming is different. But also, if you have a slow heart rhythm and you need to have a pacemaker function, it isn't able to do that because it sits outside the heart. Sometimes also other therapies can be delivered by defibrillators that sit within the vessels and lead into the heart, though that's known as anti-tachycardia pacing, and can return the heart to normal rhythms when there is a life-threatening fast heart rhythm, but without shocking the heart. So is usually a lot better tolerated. And that's something, again, subcutaneous ICDs aren't able to do. So there are benefits and considerations that may mean subcutaneous ICD isn't the ideal device for someone. And these need to be made in discussion with the implanter and your doctor, really, because there are pros and cons, and I think it's useful to understand all of them. The second aspect, I think, was about, can you switch from one to the other? So as I mentioned, the transvenous systems, the systems that are conventional and sit with leads within the heart, they sit within the heart in theory for lifetime. So those leads over time get embedded down, they get scarred in, which means they can be hard to remove. And so whilst it may be hard to take it out completely, if it does need to be changed for whatever reason, there are some circumstances, quite particular ones, that may mean one puts in a subcutaneous system. But if you start with the subcutaneous system, because it sits outside the heart, the scarring process is different, and it's usually easier to explant, such as in the case of an infection.
Wonderful. Thank you, Dr. Bhuva. Dr. Bhuva, at the top of our list now, will remote monitoring and mobile/digital apps play a bigger role in monitoring cardiology patients in the future in response to post-COVID and dealing with the backlog of follow-up appointments?
Thank you, Adrian. So just in case people didn't hear that, the question was about remote monitoring and the role of remote monitoring or mobile phone applications in the post-COVID era. And I think it's really a field that is changing rapidly. And the reason defibrillators and pacemakers sit at the front of these is because these are already highly complex computers with excellent software on them that sit within the body and are large enough to contain the necessary electronics and transmitters so they can communicate with hospitals far away. If you combine that with a Wi-Fi terminal at home, it means that essentially worldwide now, it is possible for your device to deliver data back to your caring physician. And so over the COVID pandemic, we've seen across the country, I'd say, quite a remarkable switch to remote monitoring. And our experience, at least at our centre, has been that really fantastic. It's not only convenient for individuals because they have to stay home, but also we're still able to pick up issues with the device through remote alerts. It does depend on the device, and it does depend on the software within that device, but often they will have alerts that are sent directly to the clinician to alert if something's wrong in the device or the person does need to be assessed. So from that side, I think it's already changing how device clinics are working, and I think that makes it easier for patients and referrers. Like every large change, there's going to be negatives, and I think we're still understanding what those are. But some patients we are bringing in still because it may be necessary to program the device. Of course, you can't do that remotely, or that there may be subtleties that aren't appreciated through remote monitoring. The second aspect is about mobile phone applications, as well as to monitor the heart rhythm, but also mobile phone applications that interact with the device. So you're able to read your own settings on your mobile phone. And those are now becoming available with the latest versions of software. And I must say, I don't know whether those are making care better. I think some patients do enjoy them, but I think we have yet to really define what their role is, if they're adding value, or whether, like some things, there's a risk of just being another app But I think for some people, they will really appreciate having the extra control of having an access to their device. For remote monitoring, you can now have a single lead ECG on your phone, or you can download an application through which you're able to monitor your heart rhythm. Do they provide complementary information to pacemakers and defibrillators? It really depends on why you want to do it. So your defibrillators or pacemakers will often have leads sitting within the heart, so they provide very good signals of what your heart rhythm is doing, and they have their own protocols of when to alert clinicians to something that might need to be actioned on. If it's being performed to look at something specific, it really can have an additional value, but it depends on the role and the context.
Thank you very much for that comprehensive answer. Dr. Bhuva, the question here, I've been told that if you have an ICD, you shouldn't use conduction hobs or travelators. Is that correct?
So I think this is a very important aspect of living with either a pacemaker or a defibrillator. So these devices work because they have electrodes sitting within the heart. They read the electrical current your own heart produces. But of course, in the modern world, the heart isn't the only organ or object that produces currents. Everything around us does nowadays, from our computers to induction hobs to arc welding equipment. And people have all sorts of hobbies and interests and lifestyle, meaning that there are a lot of different equipments that can cause possible interaction with the device. And the risks are that the device mistakes it for the heart. And if it mistakes it for the heart, it will decide the heart doesn't need to have a pacemaker function, so it may pause. Or for a defibrillator, whether it will shock the heart inappropriately, thinking that there's a fast heart rhythm, which is actually an electrical source from outside of the body. So most of the electrical sources nowadays in day-to-day life don't interfere with your device. This has changed over time. So 10, 15 years ago, there was a lot larger electromagnetic interference, partly because of the filtering from the device, partly because of the devices themselves. Your microwaves now are safe, and your induction hobs are typically safe. If you have any doubt, the first point of call is to check with your device clinic. And the reason for that is because the manufacturers will develop complex tables of which devices interfere, if they do at all. And so that's probably worth doing. And if you're worried prior to implant, we can also consider that as well. And often things can be tested, and the manufacturers are very good at looking to see if there are possible interactions. The one thing to say, with all having said all of that, is that new devices do come out all the time, and these can vary as well. So, for example, with phones, we say keep them 15 centimeters away from the device. That hasn't caused many problems with modern generations, but the latest iteration of the iPhone, for example, has actually caused a magnetic effect on the device and changed its function. So we're still learning about these every day.
Wonderful. Thank you so much, Dr. Bhuva. Dr. Bhuva, the next question, I wonder if you are going to be able to answer this. I'll put it to you anyway so you can decide. What are the rules about driving after having an ICD implanted, or after having an ICD deliver pacing or microshocks or defibrillator shocks? Now, just to precursor this as well, please, just to say that Cardiomyopathy UK has a fact sheet on different types of driving licenses and ICDs, but I'll leave you with the question from there.
Thank you, Adrian. And I think that it's very hard to give a single answer to that question, but it's an important question and consideration. So before an implant, I think it's important to understand the implications of driving, both for the implant procedure itself, but also if the device detects any heart rhythms which are abnormal or treats any life-threatening heart rhythms. And the advice varies both on the severity of the heart rhythm, whether it causes someone to black out or not. It will vary on the type of treatment the device delivers, and also the recommendation varies on the type of driving license one has. So you need to take that all into consideration. And I say that working in the United Kingdom, each country will have its own regulations. And so I'd say just check with the driving body and your clinician. So in the UK, this is the DVLA. Their website has a comprehensive list, and if any doubt, call them first, and they can guide you through. And of course, your pacing department as well will be able to give you a specific answer.
Thank you. Should the decision on what type of ICD to implant, transvenous ICD or SICD, be based on your current situation, or does it need to take into account possible developments? For example, I don't need pacing now, but I may do in the future.
So both have advantages and disadvantages. We've said the subcutaneous ICD doesn't have leads within the heart. As you've rightly pointed out, that means it can't deliver pacing. It can't deliver anti-tachycardia pacing. So perhaps treating life-threatening heart rhythms without a shock. For some people, that will be absolutely fine. For others, that may be functions that are useful. And the way to decide that is really in discussion with your clinician, looking at all your data, looking at what's known about your heart and the weaknesses and what's expected in the future. There are a number of different factors that should go into that decision.
That makes sense. This one, maybe you can explain a little bit more about what this means, but what is the evidence basis around WISE CRT technology? So
WISE CRT is a new type of cardiac resynchronization therapy. So I've said CRT is a very effective therapy for some people, both to improve the symptoms of heart failure, but also to help people live longer as well as feeling better. But not everyone responds to it, and there are complex reasons behind that. The other factor is that a lot of people can't receive CRT because technically it's not possible to implant that third lead that sits on the far side of the heart, if you recall my picture from earlier. And so what that has led to are development of other systems. The WISE CRT is a wireless stimulation system. So WISE stands for wireless stimulation with an endocardial electrode. So there's a lead that doesn't sit on the outside of the heart, but rather there's an electrode size of less than a fingernail that sits within the left side of the heart. So that's implanted through a catheter that goes through the heart, and the electrode is left there. It then communicates with a receiver that sits under the skin, like a subcutaneous ICD, but smaller, and uses ultrasound to do that. And the way it does is it delivers contraction using that extra electrode. It's a very new system, so we're still understanding its use, and there are studies going on, and we're part of those at our centre. But those studies are really focused first on the feasibility. Is it possible? Can it be done safely? And then I think after that, we can really understand whether it's effective or not. So I think there's a lot of work and exciting work that's going to happen in the next few years in that space.
Thank you, Dr. Bhuva. Our audience are really enjoying these questions and getting through as many as we can. I think probably this might be our last one. I need an MRI. I have some tips from my original ICD left inside me. When I had my new lead and device fitted, can I have an MRI?
So this is a really important question. The context of this is that it's really important to know what the device is. We've talked about MR conditional devices, those devices that are tested to undergo MRI, and other devices that are not MR conditional, that we can scan under strict protocols. What I haven't mentioned is that there are other scenarios that can lead to higher or even lower risk, depending. One of those is if a device has been taken out, but some of the lead has been left within the heart for various reasons. There are other scenarios too, but those won't fall into the manufacturer's testing conditions. It's impossible to test every scenario. And we worry that those extra aspects of lead can lead to increased heating from the use of an MRI machine. Our experience worldwide is in the order of a few hundred scans, so it's really quite low. And I'd caveat that also with the fact that it will vary depending on the type of MRI scan, the length of the lead as well. We do worry, though, of that increased risk. But because of that quite early experience, there are centres in the UK and abroad that perform MRI in those settings who are more used to doing it, who have the technical experience to be able to do that. it's always a risk versus benefit. It's really hard because the space is changing very quickly, both for the referrers who may not be aware of the latest technologies and the MRI centers who may not have that experience. And that's why we're trying to develop a network of these things across the world, but particularly in the UK. And so if there's a good justification for these scans, the referrer should get in touch with the center that can do it or ask for help.
Really appreciate the time. Thank you so much, Dr. Bhuva. I think we'll have to bring it to a close there. What I will say to our audience is there has been lots of questions, and I will try and move some of those over to the clinical Q&A that follows. But again, my sincere thanks to you, Dr. Bhuva.
My pleasure. Thank you.